This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, I'm Dr. Rob Page and welcome to Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that is helpful in terms of making their healthcare decisions. And I feel fortunate to have with me today Dr. Greg Mancini. Dr. Mancini is a surgeon who works at University Surgeons at the University of Tennessee Medical Center. And he is here today to talk to us about hernias.
Thanks for having me.
First and foremost, hernia. It's a term I know that all of us are familiar with. We're all familiar with the turn your head and cough, sort of, evaluating for hernias. But what exactly are they? I mean, what do they constitute as terms of a medical problem?
Sure. So hernia is a very wide spectrum of disease. In general, a hernia is a defect or a hole in the abdominal wall. So you probably haven't thought about it, but between your ribs and your pelvis, there are no bones except for your spine. And so all of the organs in our belly are held in by essentially a patchwork of abdominal wall muscles. So we have the abs in the middle and the obliques in the side. And we have seams in each of those that join those like panels, like in your pants or clothes, that join those together. And those have the responsibility of holding all that organ work inside. Mm-hmm. And a hernia is a weakness in that. And those weaknesses come at natural weak spots, say the groins, and the belly button, which are natural weak spots. But they also happen where previous surgery may have happened. So incisions from surgery are the number 2 cause of hernias. And so that's another way that these abdominal wall defects occur. So the hole that exists allows internal organs to push through, and that's the bulge that people see that we call hernias.
Gotcha. So now I can imagine out there are a lot of patients who've been diagnosed with hernias who have not had surgical intervention, who have not necessarily had any sort of medical treatment for it. And why is that? Why is that there's some that get treated and some that don't get treated? And in what circumstance would you need to treat a hernia?
Sure. So the majority of hernias aren't fixed because patients don't walk into doctors' offices. Okay, so they're untreated.
Right.
But the ones that come in to the office, what we do is we assess them for their risk. Okay, so let's talk about groin hernias. These are the things that are the typical turn your head and cough type of things. And what we do is we kind of have 3 buckets for those. So the first bucket is ones that are just slightly bulging. And that's where maybe a little fatty tissue is pushing through the wall. And those aren't dangerous. And those can be fixed and may even wait a few years to be fixed. And then the next bucket is the ones where there's actually bowel pushing down. And so we can feel that on an exam, and those are the ones that should be fixed. Because if the bowel is left there for a period of time, there's a risk of the bowel becoming entrapped. The third bucket is the ones that should have been fixed 10 years ago that people just haven't done, and that's when they have this large bulge that may go all the way down through their thigh and into their private parts, for men down to the scrotum and women down to the labia, and that oftentimes is just ignored. And so patients who don't have access to healthcare may ignore hernias. And so those are important things that we treat and evaluate. So we'll let people know where they are on that risk and the timing in which they should get these repaired.
So if I'm a patient who's had a hernia and I have one of the with the bucket 2 or bucket 3 hernias.
Yes.
What are the risks of me having this hernia? If it's something that I don't like cosmetically, that may be one thing. But why should I get this fixed?
Sure. The number one risk is pain. So if you're doing basic activities during your day and you're having discomfort and you're avoiding activities, particularly if you're avoiding healthy activities, say you're not going for walks, you're not participating in workouts or activities because every time you do it hurts. Or maybe your job requires a lot of labor and you're lifting, and every time you lift a heavy thing at work, you're hurting. Well, those are patients where that pain is a sign that this should be fixed. So pain is probably the number one reason why people get it fixed. The other is if the bowel is out in the hernia and doesn't go back in. Now, many of the ones that are out there, patients can lie down and relax and things will reduce, and that's fine. And patients do that for years. And in fact, in many less hospital cared countries, you may wait years to have a hernia fixed, and some are okay to watch. But in general, pain is an important one, and if the bowel does not go back in, those are two keys that we should be operating sooner rather than later.
Now you mentioned that the bowel going into a hernia. So this is actually part of the, that our small intestine that actually goes into the hole that's made in the abdomen. And I guess the issue would be is if you can reduce that or actually push back what's in that hole, what would be any other risks of that acutely that patients might not actually consider?
Sure, if there's any color change to the skin, that's actually a pretty worrisome sign. So if you have bruising or redness to the area, or if your bowels are blocked. Yeah. So say that you're having nausea or vomiting and it's lasting a day or two, and things just aren't moving through. That could be a sign that you could have your bowels trapped in that bowel blockage, just like a water hose that's kinked, can't move things through, and then everything kind of backs up and you begin to get sick and nauseous.
So not just inconvenient. This could be something actually life-threatening.
Oh, sure. We see these in the emergency room every day, and some are there for pain, and those can be treated, and some are there for bowel obstructions, and they are treated in the middle of the night.
Gotcha. So one of the things that you do differently in your clinic is you don't treat hernias the typical way that we've heard of in the past, which is generally it's a fairly significant surgery where patients are out of commission for a period of time. They generally have to stay long in the hospital. You do things a little bit differently.
So we keep adapting to these hernias. So
yes.
Hernias have been around since Hippocrates, and will be around long after you and I are gone. The technologies continue to evolve, and so we have minimally invasive techniques, robotic techniques, and the materials that we use continue to evolve and become much more bio-friendly. So those are things that, as those technologies change and we apply them to our patients, we adapt to provide better care.
So typically in the past, if I had gone in maybe 15, 16 years ago and wanted to get a hernia repair, what would be the average time for me to spend in the hospital versus what is it now?
Sure. So most all of it's transferred to outpatient care. Right. So for an inguinal hernia, for a good while, since about the mid-'80s, it's been an outpatient surgery. So the groin hernias have been come in and go home the same day for a while. That's moved from being open incisions to laparoscopic or robotics incisions for many folks. The incisional hernias that happen in the middle of the belly, those typically were a 2 to 5 day hospital stay and about a 6 to 8 week recovery. And with the minimally invasive techniques, those have turned to outpatient as well, and people return to work in 2 to 4 weeks.
Now you mentioned something about the materials that are used to repair this, because I know that there had been issues in the past about patients who'd had a certain type of mesh to repair these hernias, and there have been some problems with that.
Yeah, so this is one of the most common asked questions amongst patients is, what are you putting in me, and can I look at it?
Right.
And patients should, and we have samples in the office of the materials that we put in folks, because they should look. They go to an orthopedic surgeon's office and see the hip joint that's going to go in and see what it looks like, so we have our mesh materials for people to look like. I think one of the misconceptions about mesh is that it's somehow this evil or dangerous material, when in reality it's exactly the same material we use for standard stitching. So it's either a long strand of polypropylene, which is plastic, or polyester, which is plastic, comes on a large spool, and for your suture material that you sew up with, it's just a single strand. Well, they take the same material and put it on a loom and weave it into this three-dimensional kind of mesh, which looks like a screen. So it's no different in the material in most cases. It's just more of it.
Gotcha.
And the reality is that anytime we put a foreign material into somebody, whether it's a hip joint or a breast implant or a pacemaker valve, or pacemaker or heart valve, those are foreign-made things, and the body sometimes doesn't like them. So people can rarely but can have allergies, or patients can get infections. And infection is probably the largest problem with any prosthetic we put in. So we're hyper-focused on preventing infections for patients who have hernias.
Now what percentage, is in a general sense, do patients get, if they are going to have a complication such as allergy or infection, is that what percentage of patients is that generally?
So the allergies is probably 1 per 100,000, so a pretty rare event. Yeah. The mesh infection is probably about 1 in 1,000. But if you have a mesh infection, it's a real changer. You're talking about another surgery, at least one, to remove the infection and remove the mesh, and then you're still left with your hernia. And so those are things that we take very seriously, and the best treatment is prevention.
Gotcha. So, so we're still talking about a very uncommon event. We're talking about
very
one every
uncommon,
1,000 surgeries where it actually becomes an issue. So, so if I'm a patient, and let's say I have a hernia. What steps would I go through to be evaluated by you? What steps should I go through to contact you for your clinic? Are there any things I should do ahead of time before I see you? And is this something generally that insurance will pay for?
Sure. So making an appointment in our clinic at University of Surgeons is 305-9620, I believe. The best thing that somebody can do is if you've had previous CAT scan imaging, say you went to an outside facility or you in an emergency room last month, is go get that scan, because they'll put that on a disc with all those pictures, and we'll look at that with you and we'll show you what your hernia looks like, and that'll help us understand the risk profile. Is this something that needs to be fixed now or can it wait? Those are really important. If you don't have them, we're likely going to order them for you. So avoid having to get more scans by collecting all that information. If you've had previous surgeries, it's great to have those operative notes to know what other surgeons did and what implants they used. So it's very frequent. At UT, my practice is complicated hernia, so oftentimes I may be the third or fourth person trying to help the patient, and they may have 2 or 3 other meshes in, and we're trying to figure out what is going to be different about this time. What will we do different than the last ones didn't do? So those previous notes are very helpful too.
So when you talk about a complicated hernia, you're talking about one that has been repaired multiple times,
correct,
and still is having issues because not necessarily the patients. I mean, for what reason would a patient need to come back in and have for multiple hernias? Is this generally caused by something that they just have as a congenital issue? Are these patients who generally have have higher risk factors, being that they're in a very physical activity? What sort of patient would that be?
You answered all those.
Oh.
So heavy patients are a higher risk for them coming back. Patients that are smokers have a higher risk for their hernias coming back. People that that have congenital problems, that we call them herniosis family histories, where somebody will have 3 or 4 different hernias. They'll be at Thanksgiving dinner and they'll be talking about how many hernia repairs they've had. There are definitely collagen differences that are below the spectrum that we currently understand, and why patients develop this, because it is a collagen wound healing process that's a part of that. And then when we do a repair and now we have the body and the mesh that have been put together, and then life is complicated. People have a car wreck, people have other surgeries, and they'll go through that mesh to the surgery, and then they'll need some other repair. So those are the things that are the real kind of nitty-gritty in the trenches types of things that patients live through.
Gotcha, but it's something that you've dealt with in your practice, and it would be and it'd be something of a patient who's had repairs elsewhere who may or may not think that it's that it's going to be a viable alternative for them to come back in and get an additional repair. That is something that you deal with in your practice.
We do. We have a great group of surgeons with a wide set of skill sets that are dealing with the hardest of the hardest hernias that may have been turned down elsewhere. Yeah. We have learned a lot of things from our bariatric program on prehabilitation, getting patients ready for surgery, making sure their diabetes is under control, their weight's under control, they're physically active, their nutrition's good, their wounds are healed. Those are the 5 things we do before surgery. And that may mean they may spend 2 or 3 months with us getting ready for surgery, and then when their surgery happens, they're more likely to get better success.
Right. So this is not just something where you would expect a patient to come in, you get the surgery, and then you may, and you would say, hey, follow up, if and when you need to. This is something that, you actually take the time and the effort to get to know these patients, get to actually, make sure that you know their medical history, get to know exactly what's going on with them so they can get the best care possible.
That's what we do.
Excellent. So, and you mentioned earlier what your telephone number is. Your office is located at the University of Tennessee Medical Center.
That's correct.
And if I'm a patient who has any questions about, if I have a hernia, what kind of hernias need to be evaluated, is there some place on the web that I should go check to go look and get any additional information?
Sure. So utsurgery.com is our website for University Surgeons. It has tremendous amount of information really about hernia, because that's one of our passions of our group. And so you can find great information, and in fact some videos there as well.
Excellent. Well, thank you so much for joining us here today and giving us excellent information about hernia and hernia repair.
Thanks for the opportunity.
And with that brings this episode of Doc Talk to a close. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that is helpful in making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for joining us.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.